topic about osteoarthritis from some interesting information. Now we have a Zoom version of lectures. How much time? More than 2 years ago, because all of us were present in a pandemic condition. That's why you have a distance from. But this 2 years pandemic, we have too much of information about this. We read every day about the new cases of SARS-CoV-2 infection and some others. Nowadays, I think that the World Health Association decided we have too much of vaccinated persons, that the new cases and new stamps don't find every day, and maybe after a few years, all of this pandemic finished. But I told you like this, the last 20 or maybe 25 years, we live in a pandemic of different disease. It's osteoarthritis. And osteoarthritis, why I named it like pandemic, because every year we see the increasing of new cases of osteoarthritis. If some years ago we speak that osteoarthritis, it's a disease just for elderly persons, nowadays we start to check the young patients with the clinical signs of osteoarthritis, and the new cases of this disease indicate every month, and we check that every day more younger patients get this disease. Let's start from the definition. First of all, somewhere you can find a short definition of osteoarthritis, that is a just degeneration of the cartilage. No, nowadays too much of new information about the pathogenesis of osteoarthritis told us. First of all, in Russia, we have two terms which describe this problem. In Russia, we have osteoarthrosis. That's why this term described as just degeneration. And we have osteoarthritis. In Russia, some years ago, we named osteoarthritis some autoimmune problems with the big joints. But nowadays, we tried to forget about osteoarthrosis, and we start to speak about osteoarthritis. Why? Because too much of new knowledge told us that we have a great role of inflammatory into the joint. And we don't speak nowadays about the simply degeneration of the cartilage. We speak that these terms include any disturbance in the cartilage, in the synovial membrane, in all particular tissues. If you speak about this, it's ligaments, muscles, tendons, changing of the joints axis, and some others. That's why nowadays it's more bigger term which describes the different signs of osteoarthritis. If you speak about, if you see this information in your slide, it's maybe not so new information from 15 years ago, but you check how often we start to see the new osteoarthritis cases. And you see that after a few years, maybe 5-10 years, we start to check more than 15 million of new cases of osteoarthritis per year. And which problems? Osteoarthritis is any chronic disease finished by great problems. Our patient needs so expensive treatment. Our patient needs some operative treatment. Some of them lose her normal activity as before this disease. That's why all governments and all countries paid too much money for decide the osteoarthritis problems. And we don't see any positive dynamics in the new cases every year. And nowadays, when I treat my patients and describe her anamnesis of disease, or too much of them tell me that after SARS-CoV-2 infection, after COVID, I start to see some signs in the big joints, knee joint, hip joint, and others. And I think that we try to understand why it's happened after this new infection, and what's happened generally, maybe on a pathophysiologist level, maybe on a biochemical levels, and why these patients get this disease without any colorful risky factors. If you speak about the process of osteoarthritis in all skeletal muscular disease, you see that near than 30% of all skeletal muscles problems is the osteoarthritis. You see that juvenile osteoarthritis, it's a child problems, psoriatic polymyalgia and rheumatoid. It's near than 5% from all. And if you speak about our today topic, it's so oftenly registered form of skeletal muscles diseases. If you speak about the pathogenesis, nowadays we have too much of biochemical definitions of the osteoarthritis progression, but generally it's a disturb in a so interesting balance, catabolism and anabolism into the cartilage. When we have too much of biochemical indicators, it's a factor of tumors necrosis, too much of interleukins, which increase the production of matrix proteinases, which degrade the cartilage, generally firstly the collagen, and finally the cartilage. But in our routine practice, we decide like this. After some biochemical disturb, the cartilage can save her architecture and stop to amortize the big joints. And when this process start, after this we have some few years before any clinical manifestation. I mean, that's why the osteoarthritis have a great problems. The patient have not any complaints few years. And when we start and after the day of manifestation, we made, for example, the X-rays and find the symptoms of osteoarthritis. But we must understand that we try to indicate this all of these changes early for prescribe any maybe preventive therapy, but sometimes and usually I told you like this that the osteoarthritis happened after first clinical signs. Why the incidence of osteoarthritis continue to rise? First of all, we must understand, and I told you a few seconds ago, that the patient came to us with some complaints. Usually the main complaint of our patient, it's a different kinds of pain which localized into the joint or maybe around the joint. But biochemical and the pathophysiologist disturbs happened early. And sometimes we can check any changes on the X-ray, but the osteoarthritis starts into these days too. That's why maybe we try to find some biochemical markers of cartilage disturb and check the levels of them in blood and in a synovial fluid, and like this try to find the pre-X-ray stages of osteoarthritis. And our classification just based on the X-ray changes. And before finding anything of them, osteoarthritis starts too. And we start to treat our patient just after some finding on the X-ray. For example, sometimes the patient came to the doctor examined him, made the X-ray, not find any osteoarthritis changes, and told our patient, no, you had not any osteoarthritis, let's turn to, I don't know, to your hard work or maybe some jump exercises, or maybe you can lay your joints like this and not lose any of your plus kilograms into your body, and let's see you after a few years. After a few years, this patient returned to the same doctor. We find the X-ray symptoms of osteoarthritis and told him, yeah, it's your day, today we start your treatment, but we must start to do it before, and it's a great mistake. If you speak about the causes of osteoarthritis or maybe risky factors, when some years ago, too much of doctors decide just elderly persons get the osteoarthritis because we have some involutive changes in all cartilage joints, and that's why all elderly peoples must get the osteoarthritis. I told you, few months ago I examined young woman, 27 years old, and she have a second degree of osteoarthritis. But if we want to classify the causes, it's generally genetic, non-genetic, and other outside factors. If we speak about the genetic, it's a oftenly we speak about the gender dependent. Male and female have a different localization of osteoarthritis. For example, here in Russia, in the northern part of our planet, usually we indicate the gonarthritis or problems with the knee joints by the female, and hip joints usually destroying the males. When we start to check this the statistics near the equator, near the southwest countries, we have a different situation. Usually women have a hip joint osteoarthritis, but men have a knee joint osteoarthritis. I think it's dependent by some special structures in the joints. Mutations in the collagen 2 genes, because that's why collagen 2, it's the main type of collagen which present in the hyalinic cartilage, which present in the big joints. And if we have a gene problems, that's why we have not any normal structure of collagen. That's why we have not any normal structure of cartilage. Whereas dysplasias of bone tissue, usually these problems manifestate in a young age, and sometimes for finding the first X-ray symptoms, it's more simply for us. Why? Because we understand that after some years of presenting this dysplasia, we're afraid that this young person have a young form of osteoarthritis. Overweight, it's a great problem. Yeah, and great problem after into these 2 years, because all of us, we sit at home, we watch too much of cereals, we drink too much of cola and eat too much of pizza. We have any deliveries, we have any other services which made our life more comfortable, but give us plus kilograms into our body. And don't forget that we have a gravity on our planet. That's why the number of kilograms depends which power pressured on our big joints, hip, knee, and ankles. That's why overweight, it's a great problem. And I think that this connection of Instagram guaranteed that no any persons present into the jumps stop her training plans and others, because where you can publish it, your photo from the jump, and that's why the patient starts to get another plus kilograms. Post-menopause, it's a great problem because the women have some problems with her hormones. That's why they have a general form of osteoporosis. They lose the mineral component of the bones, and that's why the bones stay more fragile. And microfractures in the subchondral area guarantee that the cartilage lose the waves for vascularization, and the degenerative problems happen at the early. And outside factors, it's various injuries. For example, any intra-articular fractures which broke the articular surfaces of big joint, and without any close or open reduction, guaranteed that the cartilage disturbed early. Overload of the joints, any acute professions, for example, I think that you agree with me, some of patients who work in an office and some of patients who develop a charcoal. It's a different levels of physical activity. It's a different levels of overload of the joints. And that's why some of these patients present into the risky factors. Playing sports. About the sports, we have a great discussion. Because the sports, firstly, the activity, the high level of physical activity guaranteed that we have a what? We lose our kilograms. But active sports work with some metals and maybe with some hard exercises guaranteed that we overload our cartilage and destroy him more faster and early. If we speak about the definition of all of these factors, we can see about the hyperplasia of inflammation synovial membrane in increased expression of all some intra-joints factors which destroy the cartilage early, concentration of CRP, and clinical effects of glucocorticosteroids. If we try to classify the osteoarthritis, generally we classify them by the cause, primary or idiopathic. That's why we don't understand and we can't find the main cause of this disease. How we can classify it depending by the localization. Less than 3 joints and definitive more than 3 joints. Hand joints, foot joints, knee joints, hip, spine, and others. That's why all our synovial joints can be destroyed by the osteoarthritis. And generalized form, it's a usually erosion kinds of. It's a primary. If you ask me why this patient get this kinds of osteoarthritis, and if I named it like primary or idiopathic, nobody can understand what is the main cause. Overload, maybe obesity, and some others. Nobody understands that. And if you speak about the secondary osteoarthritis, usually this osteoarthritis happened after some traumas. It's some intra-articular fractures, tibial fractures, femur fracture, head of the femur fracture. Some problems with the growing of the bone tissue. It's a Perthes disease, syndrome of hypermobility, etc. Metabolic disease, achondrosis, hemochromatosis, Wilson-Penemal disease, and others. All of these diseases guaranteed that the nature into the joint stay differently, and that's why the cartilage can stay normally in a longer time. Endocrinopathy, acromegaly, and diabetes, and hypothyroidism. All of these things, you must know that the parathyroidal guaranteed that we have a different forms of these hormones, and they change the metabolism of bone tissue. Calcium depositus disease, it's a pyrophosphate calcium, and others. Neuropathies, Charcot disease, and other diseases, osteonecrosis, rheumatoid arthritis, Paget disease, and others. Usually, I told you like this, all of these causes is not so oftenly. Usually, we name it osteoarthritis like idiopathic because we don't know how and what is the main cause into her pathogenetics. Let's speak about the diagnostic methods. The main of them and oftenly using it's a radiography and 2 projections. Why? Because sometimes in the frontal projection we don't check any changes, and if we speak about the knee joint, sometimes we can find something in a patellofemoral joint, but in a femoral tibia joint we don't find any changes. If you want to understand what's happened with the bone tissue in this situation, and you don't understand something after classic radiography, you can use the CT scan for see the congruation of the bone of the joint surfaces. If you want to detailize them or maybe mark the cartilage disturb, you can make the MRI. MRI can show you the definition of intra-joint structures, about the meniscus, ligaments, and others. If we speak about the knee joint, the labrum, and other structures, if we speak about the hip joint. And sometimes the doctors use the ultrasound, but I think it's so doctor-dependent method, and how the doctor describe these investigations depends. The degree may be the final diagnosis. But usually in a routine practice, we use a radiography, CT scan, and MRI. How we classify the stages of osteoarthritis? We have international Kilgren-Lawrence classification, and all of us, we must use this. There we have 5 stages, but usually we don't name the 0 stage when we have not any radiography findings of osteoarthritis. I told you like this classification based on a 4 X-ray things. First of them, it's a narrowing of joint space. Sometimes these things can happen in the 2 compartment of the joint. If you speak about the knee joint, some it's a monocompartmentally. Second, it's a subchondral sclerosis. What is it? When we have the problems with the subchondral bone and the cartilage, it's just some special kind of the soft tissue. The cartilage have not any vessels. That's why if something wrong there under the cartilage into the subchondral bone, that's why the cartilage losing any ways for getting some food. That's why the volume of subchondral sclerosis, it's some symptom which describe as the cartilage condition. Else, it's a bone spurs or maybe osteophytes. I don't tell you that the cartilage have some brain and something else for save himself, but this new growing bone tissue, it's maybe some safety process for decrease the volume of the joint movement. That's why if we limited this, we can limit the pain syndrome. And the last X-ray symptom, it's a changing of the joint axis. Usually we speak about the ankle joint and knee joint. You know that we have 2 main groups of the changing of the joints. It's a varum and valgum deforming, and you can change, and you can see all of them on X-ray. These slides show you the degrees of osteoarthritis depending on how all of these X-ray symptoms we can check. If in the left knee joint, we see that the joint space the same in the 2 compartments, in the 4th degree, you see that in the middle compartment, we don't find any free joint space. You see that subchondral sclerosis is, or you don't forget that all of X-rays, it's a negative picture. That's why if we want to find something compactly, this thing seen more widely on the X-ray. That's why you see that the area of subchondral sclerosis is more bigger. You see that we find the new growing bone tissue around the epicondyles of tibia and femur. That's why it's a bone spurs. We can find in the prominence of tibia here. And this X-ray don't show you any changing of the axis, but I told you, if the patient's leg seem like a cowboy leg, it's a varum deforming. If we have an X deforming, it's a valgum deforming. And usually the terminal degree of osteoarthritis include the changes of the joint axis too. Signs of osteoarthritis, clinical. First of all, when you examine your patient, you can see if it's not bilateral form of osteoarthritis. You can find that some of your patients join more edematosis than others. The patient have a starting pain syndrome, usually in the morning. The patient have a stiffness which progress into the timing of the day. And the patient can show you where the most painful area presents. Diagnostics methods. If we speak about the positive and negative things when you use the X-ray and MRI, if I can make the MRI for all of my patients, when I try to find any cartilage disturb, I made the MRI for all of them, because the MRI is a more informative method. We can see the cartilage height, we can see the subchondral cyst, we can see the osteophytes, all of them. But not forget that nowadays we try to collect the monies. That's why MRI more expensively than X-ray in clinical recommendations for osteoarthritis treatment and diagnostic of them. We must use as a routine method X-ray. X-ray on show us something interesting, and sometimes we can lose, and we can find the early degrees of osteoarthritis. If you want to examine if you want to find the clinical form of osteoarthritis, before that we speak about the stages. If you speak about the clinical form, you can use the diagnostic tools, or maybe it's a different combination of questions. Because as any chronic disease, osteoarthritis have a clinical forms: compensation, subcompensation, and decompensation. Sometimes we use the mixed form of all of these questions. Sometimes we use one of them, but all of these things based by what? By social activity of our patient. If our patient can buy something some vegetables in a magazine which present near her apartment, we understand maybe generally that it's a subcompensated form. If the patient non-cross any 100 meters near her apartments, I told you like this, it's a decompensated form, because all of these question agglomerations have near than 15 questions for describe the limited of social functions of patients. And sometimes the doctors in a short examination of our patients forgot about this and don't understand in which degree of, in which phase, clinical form of osteoarthritis our patient have. Just degree and that's all. Don't forget that we must give him a form 2. The main clinical signs or manifestation is a pain, deformity, and joint stiffness. When the patient came to you and give you these complaints, first your opinion about her diagnosis, it's thinking about osteoarthritis. Usually, and you must detailize the pain syndrome because different joint problems have a different details of her pain syndrome. For osteoarthritis, characterized maybe like this: the morning stiffness and starting pain. If the patient need more than 30 minutes for decrease this morning stiffness and and limited of function, our patient have a decompensated form of osteoarthritis. If the patient have a usually night pain, that's right, the patient have maybe so acute inflammatory component, and we try to find some autoimmune problems. But usually our patient have not any blockage, joint pain. If our patient have that, you must check the condition of intra-articular structures like meniscus and ligaments. And if the patients have often the synovitis, if you try to treat him conservatively or you try to evacuate all of this fluid, let's start to think about the autoimmune nature of these things, or let's find something intra-articular bodies, or we named it like articular mouse, which can make the stress for synovial membrane, and like this membrane starts to produce more synovial fluid than in normal conditions. Criteria for early gonarthritis. We have a different international associations about the osteoarthritis problems, and they try to find something for some signs for firstly diagnose the osteoarthritis in the early stages, and secondary give them more earliest treatment for prevent the early cartilage disturb. That's why they give us, I insert these things into the slide, it's just for understanding, because in all countries we have different opinions about these criteria. Some of associations give us non-think about the X-ray changes, because X-ray changes happen so late. That's why you lose some some time for patient's treatment. Some criteria give us that we must make the arthroscopy and try to touch the cartilage for understand it. Some of these associations told us made the MRI for all of your patients. I agree with some criteria, but I understand that in real life, sometimes you can make all of these investigations for your patient because the insurance companies don't understand it. And maybe I decide like this, that if I find some of these criteria, and if I find the big number of risky factors, I prescribe the early treatment for osteoarthritis. But sometimes the patients don't understand. You told him that you must use some drugs, you can change the maybe philosophy of your activity, you can change something into your food for lose some kilograms. And the patient told you, doctor, I have not any complaints. Why you tell me about this? You try to tell him that let's wait after 2 or more years. You start to check the first pain syndrome into the each joint, but the patient sometimes don't understand it. If we speak about the treatment of osteoarthritis, we decide like this. If our patient have a main complaint like a pain, stiffness, and maybe deformity of this joint, that's why the strategy of our treatment and the first steps, it's a war with the pain complaints. And with other big question which we try to decide, it's a save a cartilage. I don't tell you regenerate the cartilage, I told you the save. And if we speak about the symptomatic treatment, if the main patients complain it's a pain, that's why first our step, it's a analgesic therapy for our patients. That's why we use the special and also special painkillers. We can do that by systemic therapy. We can prescribe him the small doses of glucocorticosteroids if our patient has some autoimmune problems. We can give him the different kinds of unsafe drugs, and don't forget that we must make this choice for the unsafe drugs so intensively because they have too much of terrible problems. And the first of them, it's a cardiovascular problems and cardiovascular risk because unsafe drugs increased it. All of the safe drugs have some ulcerogenic effects, some of them dependent by the dose, some of them dependent by the period of using. Sometimes the patients have which complaint, and don't forget that too much of problems with the coagulation system of the blood because the so long period of unsafe drugs guarantee that our patient have a decrease of thrombocytes level, and too much of these things. That's why when you prescribe for your patient any unsafe drugs, you must examine him so deep. You must understand all risky and find unsafe drugs first of all, and choose the dose when you want to use. And nowadays, I told you like this, in each country is the gold standard. It's an naproxen, it's a aceclofenac, and some special drugs from capside group. It's heterocapside. It's other drugs which have a lower cardiovascular risky, non so high ulcerogenic effects, and other. But don't forget that when you prescribe your patient this drugs group, let's check him. Let's tell that your patient must return on a secondary examination after a few weeks, and non-prescribe your patient uncontrolled use of them. Glucocorticosteroids, it's a well drugs for decrease the local inflammatory. It's well drugs for shorter painkiller effects, but we can use him generally, we can use him locally into the joints, but don't forget that you must use this drug so freely, because after a few times this painkiller effect starts to show us cartilage problems. And basic therapy, it's a chondroprotectors. I forgot to insert this special slide into my student lection, but too much of farm companies give us the well definition of your chondroprotectors drugs, that they regenerate the cartilage, the joints stay normally and on a few long period, but no. The effect of chondroprotector drugs is what? It's just the decreasing of cartilage destroy, and that's all. For example, if your patient starts to use any drugs on a second degree of osteoarthritis, if after a few years you made the next X-ray and find that your patient rests into the second degree of osteoarthritis, it's a well kind of treatment. I told you fairy tale that if you start to check your patient, starts to treat your patient on a second degree, and after a few years, after chondroprotectors using, you see the previous stage of osteoarthritis. No, it's a medical fairy tale. It's an NSAIDs classification. Well, I think that all of you must know this classification from pharmacology department, and you woke up and lay back with this classification. This is so big and for everyday using so hard to understand, but I told you like this. You can use more safety kinds of these drugs, and every day the farm company try to find the special safety form of these drugs. Which of them you use into your practice depends where you do this practice, and depends by which country, which drugs have any safety levels into these countries. It's a terrible effects of NSAIDs drugs. I repeat this for you, and I show you these things in a so yellow color. And please don't forget that all of these terrible effects can happen. And don't forget that usually we treat elderly persons with too much of somatic problems, and all of these negative effects can increase or maybe made the decompensative form of your high blood pressure, of your problems with the kidneys, with the hyper and other. Local therapy. First of all, I start the treatment of my osteoarthritis patient with some discussion with him for maybe modify the risky factors. But it's a fairy tale that you told your patient, please, let's change your working place because it's so hard for you. And after that, maybe you save your knee joints. He seen on you, told you, doctor, you're an idiot, how I can change my working place. I get the money there and I have not other ways. But this speech you must make for this patient. Why? For describe your patient's all risky problems and talk him about the future condition of your joints. It's a non-pharmacologic effects on the cartilage. Pharmacologist saving of the cartilage, it's a tablet of the chondroprotectors. It's a bicomponental drugs which include the chondroitin sulfate and glucosamine sulfate for saving the cartilage, any intra-articular injections of hyaluronic acids, and some others. And non-pharmacologist effects on the para-articular structures, it's all our physiotherapy effects. We try to save the para-articular, the tonus of muscles and ligaments. Like this, we rest our joints more stable, and the more stable joints staying into this degree of osteoarthritis more longer period. That's why I told you about this in and these exercises and non-pharmacologist effects on your cartilage, of your patient's cartilage, but it's so difficult. Social definition, or maybe definition of the social status of your patient, it's so hard for change. And for example, nowadays in Russia, can you tell any patient that you must find another working place? It's so difficult for me. If we speak about the non-pharmacologist, we can use any special braces, any special car sets for fixing the joints. But I told like this: if you start to use this thing for the patient, maybe if we see this situation, like this, we have a deformity of our patient knee joint. If the patient start to use any car set for uncompressed and more pressured area, like this, you can reduce the pain syndrome without any maybe higher dose of NSAIDs drugs. But if the patient have a normally access and starts to use the brace, yeah, the patient feels himself more comfortable, but he lose the tonus of her muscles, and these muscles, it's a dynamic stabilizer of the, for example, knee joint. And sometimes, I don't know, so warm outside temperature, the patient non-use this brace, rotate or maybe made some high flexion or extension, and without any normally tonus of these muscles can broke any intra-articular problems. Why not in a non-pharmacologist treatment of the cartilage, we can use some arthroscopy methods. It's aspiration, because like this we can change the all fluid in the joint, we can lavage and debridement them, and like this we decrease the level of all pro-inflammatory agents which present into the joint, and like this can give our cartilage another time. It's a definition about the chondroprotectors. Some of doctors tell me that the patients don't give us any results of chondroprotectors using. But I told him like this year, and told for my patient, if in the next year on the next control X-ray we find the same osteoarthritis degree, it's a winner nowadays. That's why which problems our patient must use these drugs for a long period. You check 3 to 12 weeks, twice or maybe more times per year. That's why the patient started for the so long using tablets, but I prescribe my patients usually tablets, because injections, intramuscular form of chondroprotectors, it's not so compliant drugs, because it's not so comfortable. 24 injections every day into gluteus area. And these things can finish it by any purulent problems, and the patients who try to save her joints present in the purulent surgery department with some drainages into her gluteus area. That's why let's use the more compliant forms of the drugs for patient feel himself more comfortable into your therapy. If you speak about the chondroprotectors, we have a different, we have 3 generations nowadays, and nowadays too much of doctors and associations decide that just combination drugs, chondroitin plus glucosamine, it's more effectively combination, and that's why we try to use this. And now I don't show you this. It's some question. If we speak about the innovative methods of osteoarthritis treatment, 25 years ago we started to make intra-articular injections of the hyaluronic acid into the joints, and we tried that we see the regeneration of the cartilage, because the hyaluronic acid is our everyday young feeling and everyday losing of our age. But I told you like this, yeah, we have some cool effects of these drugs. Why? Because firstly, it's a lubricant for the articular surfaces, and secondary, or hyaluronic acid increase the production of some cartilage structures. But these drugs non-save the cartilage fully, and the great problems, this is they are so expensive and not all patients can make these injections. Usually we inject him intra-joint space, but sometimes nowadays some authors told us that we can use him para-articularly for save the tonus of all muscles and ligaments. This is other para-articular treatment. It's our physiotherapy, and some doctors forgot that we have well results after using laser, magnetic field, and some magnetic field with the combination of any drugs. All of these methods have a well effect on the para-articular tissues, decrease the pain syndrome and other. But the patient must make so high number of these procedures. The patients, all effects of these procedures have known so long time effects, and the patient must repeat it. And if we speak about and the more effectively these methods happened in the early degrees of osteoarthritis. Terminal stages, no. It's interesting. Another thing of osteoarthritis physiotherapy. First of them, it's electromyostimulation. Like this, we return the tonus of main muscles which fixed the joints without any exercises, hard work in the gym. But the patients have not any well compliance. Why? Because you must make near than 100 procedures. That's why near than every day 2 months procedures, and the patient don't want to wait too much time for for waiting effects. And extra corporal sound wave therapy, the idea of this method, it's increasing of subchondral vascularization of the big bones. Like this, we try to save the cartilage, but I told you it's a first or second degree of this disease. On the terminal degrees, no of any methods have a great effects. This is so cool therapy, so comfortable, so warm. I insert you this. It's some special drugs. It's a application therapy. It's a capsaicin, different compressors and others. The patient tried to cover her joints by anything, by any smell, non so well smells fluid, for decrease the pain syndrome. But I told him like this: it's a just comfortable feeling. You feel you need, don't forget that any joints don't like any high temperature. That's why non use any heaters on the big joints. And this is a grandma therapy. This is her decision that they want to treat himself like this. Innovative methods. We can use the special, we try to make the autologous therapy. We take some milliliters of the patient's blood, centrifugate them. We name this term in like a PRP therapy, and re-inject this activated plasma into the patient joint, or maybe para-articularly, and too much of authors give us that we regenerate the cartilage like this. I don't prove this because I try to use this therapy. It's this therapies came to us from cosmetology's medicine, and they told us that we regenerate something there, and why not you can regenerate the cartilage. There's this kind of therapy so expensive, and I don't find any positive moments. But I must tell you about this as a new methods of osteoarthritis arthrosis therapy. Operative treatment, the first step, it's a arthroscopy, it's a video scene of internally joint space. We can examine the articular surfaces. We can make the chondroplasty for when we take some cartilage from unpressured area, transplantate them to the injured areas, and like this give some time for a joint using. We can make the osteotomy for trying to change the joint axis, and like this uncompress each compartments of the knee joint. Finally, maybe the final of all osteoarthritis, and I start my speech with all of my patients, that you must understand that nowadays nobody can grow the new cartilage into your joint. And finally, all results of osteoarthritis, it's a total knee or hip replacement, or total arthroplasty. But this time, when you present into our therapy, we can make this therapy more longer, because the best joint for using it's your native joint. You can make this operation after a few years, but this is big operation, and this operation have too much of risky factors. And when we change your joint, it not doesn't mean that you can use your joint all of your time of life. Why? Because the period of joint of prosthesis living near than 15 or 17 years, no more. After that, the patient need another secondary replacement. This is more difficult operation, and the patient into this time more older, on these 15 or 17 years. But nowadays we can find anything else for save the patient's joints, and we made the total arthroplasty. And I told you, if I give this idea, and when I told this idea for my patient, some of them starts to think, because some of patients afraid these big operations, afraid any complications, and starts to change something into her life. It's a X-ray scene of the joint replacement. You see that we cut some parts of the articular surfaces of the bones. If you speak about the hip joint, for example, we cut all neck and hip. If we speak about the knee joint, we cut the articular surfaces of the femur and tibia. Sometimes we made the prosthesis of patella too. Sometimes let's rest him in the native of our patient. And I told you like this. Finally, I read 1 hour, so short lecture. I understand all of my words today.
Yes, sir, understood.
Thank you so much. That's why